Lovely, thanks, Nathan. Madam Vargas Fulcher, good morning and welcome everybody to this public board meeting of NHS Highland today on the 25th of March. Doesn't time fly? Welcome everybody and welcome to our board members and any members of the public and press who might be observing with us virtually today. Before we get going, just a bit of usual housekeeping. You will see that the meeting is being recorded so that we can upload that onto our website for other people to watch back if they want to. And if I can just remind everybody to stay on mute if you're not contributing, just to reduce any kind of background noise. And if you want to take part in the discussion, either a question or a comment, I'd ask everybody just to use the hands up function. We don't use the chat function in this meeting, so hands up only if you want to pitch in. Lovely to see you all this morning. And before we start, I have a few people things to address. Firstly, I'd like to welcome Dr. Heather Bain, who's joining us today from the University of the Highlands and Islands. Welcome, Heather. Heather is attending today on behalf of Brian Williams, who has been to our board meetings in the past. So it's lovely to have you here with us today, Heather. We also have some other changes coming up, so I'd like to take a few moments just to give some words of thanks to a few colleagues who are moving on in different directions and for different reasons. Firstly, I would like to congratulate Ruth Fry. So Ruth, who all of you will probably know, who's done a sterling job with us in our team leading up comms for a while now. So Ruth is taking up an appointment as Chief Officer for Human Resources and Communications at the Highland Council. So we're glad that you're not going too far away, Ruth, and we'll still be able to, I'm sure, cross paths in one way or another. So Ruth has been our Head of Comms and Engagement since December 2020. So during some really challenging times for all of us, and Ruth led her team very skillfully, playing a really key role in lots of staff engagement, external comms, doing our listening, learning and living our values work, weekly roundups that many people will be familiar with, dozens and dozens and dozens, if not hundreds of stakeholder briefings, loads of work around our Together We Care strategy, which was really important for us, working on things like our chief exec cascade briefs, our vlogs, leading the refreshment of our website, the work around our comms and engagement strategy. Ruth has made such an impact with regards to our comms and engagement. And that impact will be felt for a long time. So I want to say a huge thank you to Ruth for all of her hard work and the positive impact that you've made for us, and wish you all the best, Ruth, in your new role with the Highland Council. Hopefully we will still see you about. And secondly, another Ruth. So we've got all the Ruths today. So a huge thank you to Ruth Daly, who is our board secretary. Obviously critical in things like this in our board meetings. So Ruth will also be leaving us soon. Ruth's been in post with us since 2016, so quite a long time ago when things looked very different. Ruth and her team have worked really hard getting up in running different systems and processes that we use for our governance. Ruth's engaged and supported various reforms we needed to make, and has been a key member of staff in turning around bits of work that have been really important for us. There was of course, the management of our emergency governance arrangements during the pandemic, taking care of induction of all our various non-executive board members, and of course the huge amount of work that went into our self-assessment and the action plans associated with our blueprint for good governance. So that was some really key pieces of work that Ruth led, and I'd like to say thank you to Ruth for all of her contributions, and wish her all the best in the future. And last but not least, a very special thank you to my vice chair, Anne Clark, who is leaving us at the end of the month. So Anne's term comes to an end at the end of March, and all of you will know just how hard Anne has worked with the board over all those years. So Anne's brought her extensive experience carrying out her board membership and chaired lots of different committees and been a really pivotal contributor to so much of our work. Anne's been a dedicated and active member. You've really gone above and beyond, contributing significantly to the business of the board and the various committees that you've been on and chaired. Leadership roles, chairing the Highland Health and Social Care Committee, remuneration, staff governance. Anne's been a really passionate advocate for quality engagement and has really driven changes in our engagement practices, addressed local and national priorities, supported partnership working, really instrumental in how we've moved forward in our partnership arrangements, particularly thinking about how we deliver health and social care in the Highland area. Anne's also a really passionate challenger around health inequalities, and that influence and push has been really instrumental in how we think about the way we move forward in terms of our public and population health and tackling health inequalities, and indeed how we think about our public health annual report and what we do with that. Anne has supported working with third sector colleagues and strategic commissioning and community planning. So really using her experience across the full breadth of our partnership work within our communities, and has championed patient experience systems. Anne has set a really, really high standard for us all. And I think you're leaving a big gap for us to fill, so we'll all have to step up to try and do that, but you're definitely going to be irreplaceable. And just personally, I've really valued and your immense support as I've stepped into my role as board chair, and I know that you were just as valued by my predecessor Boyd in the way that you've supported us in our role. So we will miss you immensely, and we want to wish you all the very best for the future. And
maybe Sarah, if I could just say thank you very much for those very kind words, and thank you to everybody who has supported me in my various roles over the years. And although I'm quite sad to be leaving the board at this moment, I'm also content, because I feel that particularly at the moment with yourself and Fiona leading the board, all those issues that you talked about that I'm passionate about, particularly health inequalities, are in safe hands, and I'm sure that the board will go from strength to strength in taking those forward. But thanks again for those very kind words.
Thanks, Anne. And although you'll be leaving us, I know you'll be watching, which is great. Might have a little picture of you just above my desk. And what would Anne do? Okay, so before we get into the main business, I also just want to take a moment to note the day of reflection that around COVID that obviously took place earlier this month. You'll have seen it in the news all over the place, of course, because it's so significant. And I just wanted to talk about it for a moment. It's been a really important opportunity for us all to remember those who sadly passed away, a time to think about the challenges and sacrifices experienced by us all, and how those have impacted individuals, impacted our communities, impacted our staff. To take a moment to think about the immense and enduring work that all of our teams across all parts of our health and social care system undertook, and to pay tribute to the volunteers and communities who, really wrapped around one another, supported and cared for one another during such an awful time. Individuals and teams across Highland and Argyll and Bute have done different things to mark the day in their own way, as I'm sure many of us will have done too. The lasting effects and impacts of the pandemic will stay with us forever, and there is much that we can and did learn from those terrible events. And so I suppose I just wanted to note it and note how grateful I am that we have the opportunity to use that time for reflection, for learning, for remembering, and for paying tribute, as I'm sure you all will as well. Okay, so we'll get into the business of the agenda now. Ruth, could I have the apologies, please?
Thank you, Sarah. Yes, we have apologies today from Elspeth Caithness and Joanne McCoy. We've also been notified that Muriel Coburn will be late in arriving, that Alec Anderson will need to leave a little bit early from 10 o'clock onwards, but will be returning. I'm aware that Emily is having a few problems with her connection, and unfortunately, Catherine Sutton won't be here with us today. Thank you.
Okie dokie, thanks for that, Ruth. Right, we'll move on then, and hopefully Emily can still contribute if her connection stables up a bit. Could I have any declarations of interest, please? Alistair.
Yes, good morning, Sarah. I had considered making a declaration of interest in my capacity as a Highland councillor, but having examined my connection to items on the agenda and after applying the objective test, I feel I don't need to do so. Thank you.
Okay, that's great. Thank you, Alistair. And Steve.
Good morning, Sarah. Morning, everybody. I also consider making a declaration of interest in my capacity as an employee of Highland, but don't judge this to be necessary after completing the test. Thank you.
Okay, that's lovely. Thank you, Steve. So that, I can't see any other hands up. So those are our declarations of interest. So I will move us on then. We have in front of us the minutes of the meeting we had on the 28th of January and also the action plan. So does anybody have any amendments that we need to make to the minute before we approve them? Anne, please.
Thanks, Sarah. So I'd just like to propose one amendment, which I have alerted Ruth to. Page 6, item 6, the first bullet point. I would suggest that we should change noted the DPH report to agreed the recommendations of the 2004 DPH report. I think that's more in line with the proposal I made it and everybody accepted at the last board meeting. Thanks.
Yeah, that sounds like a good suggestion, Anne. Is everybody happy with that? I think that's right. That seems more appropriate. Okay, so we can make that amendment. Do we have any other amendments that we need to make? Okay, is everybody happy then that we can approve those minutes, taking into consideration the amendment that Anne just put forward? Happy with that? Okay, I'm not seeing anybody objecting, so that looks good. Let's have a look at the action plan next, which I'm just opening up here. So we've got, right, just waiting for my Excel sheet to catch up with time. We've got a few proposed for close, as I remember it. And one still on there. Sorry, mine's not opening. Ruth, can you just quickly remind me which ones are for closure?
Yeah, no problem. Yes, so we have 3 that are proposed for closure. Action 30, which is a review of the corporate risk register scoring for the entry on financial balance for adult social care. Action 32, additional information has already been supplied to you on social prescribing evaluations. And Action 34, confirmation's been received that the Equalities Impact Assessment was now completed for the health and wellbeing strategy. So those are the 3 actions that are proposed for closure. There's one still outstanding, that's Action 33, which is referring back to what you were just speaking about, Anne. That's implementing the recommendations of the 2024 Director of Public Health's report, and that's still in progress.
Absolutely. Okay, so is everybody happy with those closures? And as Ruth just pointed out, we'll keep action number 33 on there until it's done. Is everybody happy with that? Yep. Okay, fantastic. Thank you, everyone. So I shall move us on now. Any matter arising from the minute? I can't think of anything. I think we're good. No. Okay. In that case, I will hand over to Fiona to take us through her Chief Executive's report. Over to you, Fiona.
Thank you, Chair. Good morning. Good morning, all. Welcome to today's board meeting. And can I just second and endorse your comments in regard of Ruth and Anne and the contributions that they've made to the organisation. I certainly, I didn't feel it might be appropriate to do emojis in a board meeting, so I felt maybe it was just better to say I absolutely and fully agree with your comments. So moving on to my report, when I was preparing my comments, I realised that I was at risk of stealing my own thunder, as the report subsequent to this on the board agenda lays out in more detail the broader principles of the main theme of my report this morning, which is collaboration. Therefore, for the purpose of this report, I intend to focus on the more local aspects of collaboration, noticing those that we already have in place with key neighbours such as NHS Greater Glasgow and Clyde and NHS Western Isles. The advent of the National Treatment Centre has greatly expanded our contribution to a wider network of delivering services on behalf of other boards, and we continue to draw on the collaborative support of other boards where we experience sustainability challenges, as I've reported previously, and we continue to, for example, in our vascular service. So as I have drawn out in my report, collaboration has also underpinned recent initiatives to address backlogs for services such as musculoskeletal physio, and bringing together patients awaiting treatment with local providers and support organisations to provide on-the-spot help has been excellent, an event that was warmly welcomed and we may wish to replicate for other conditions. So more to follow on collaboration in my next report. Just touching on vaccination, where in January we gained approval to progress greater flexibility in the way we deliver the programme in the Highland area. An outline plan will be completed by the end of the month, with rollout to follow on. And meanwhile, we are beginning the planning for the spring COVID programme, and I would encourage any eligible people to take up that opportunity when contacted. And then finally this morning, a few pieces of good news. So having undertaken successful recruitment of midwives for Skylock House and Wester Ross, I'm delighted to report that the first baby was born in Broadford Hospital on the 11th of March. So welcome to the world to baby Jasper. Congratulations to mum and dad and wider family. And well done to the healthcare team, ensuring that this delivery was safe and starting a new chapter of deliveries in Broadford Hospital. Further well dones next to the Wade Centre in Kingussie, who have received a rating as very good by the Care Inspectorate, demonstrating great outcomes in that home for its residents. And finally, further congratulations to Lochardle Pharmacy, shortlisted for Community Pharmacy Team of the Year at the Pharmacy Awards for Scotland. The team have coped amazingly with the aftermath of a car driving into their shopfront, showing determination to minimise interruption to service delivery for the public. So congratulations on that nomination, and we'll watch with bated breath as to whether the final prize heads in their direction. So, Chair, I'll pause there and I'll take any comments or questions on the substance of my report.
Thank you, Fiona, and thanks for that report. As always, a well-rounded snapshot of just a few things that have been going on. I'll take some questions and comments. I've got Steve first, please.
Thanks, Sarah. Hi, Fiona. Fiona, this is always a highlight of the board for me, so it's great to have it up front. But I just, notwithstanding the initial sort of paragraphs there, it's just the good news. And I just would encourage you to maybe do a bit more of that, because there's so much good stuff out there. And as we get into the board, all the challenges we face and some difficult governance and scrutiny that needs to be applied, I really welcome this. I think it's a great way to start the board and would like to see more good news if possible. So thank you.
Thanks, Steve. I mean, there's a risk that if I don't have the balance that Sarah was referring to, that the impression it could give is that that we're glossing over difficult challenges, or that we're not looking into the horizon. So, I think that balance is important, but I absolutely accept your broader point that celebrating what we're doing well and letting the public know that there are improvements and areas of strength that we have as an organisation, that is right that we do that, because our staff need to be lifted up when they're doing well, and the public need to have that confidence that there's a huge amount that's going really well right across Highland and Argyll and Bute. So challenge accepted, Steve. Let me see how I can strengthen the report to make sure that whilst conveying the breadth of what we do, and the awareness of challenges and risk, that we're highlighting sufficiently successes, strengths and assets. Thank you.
Thanks, Fiona, and thanks, Steve. It's a really good point. And coincidentally, Fiona, Gareth and I were having a sort of separate but linked conversation. And I think the other benefit to spotlighting, bits of good news, as well as bring a bit of balance to the conversation, so we recognize that there is a lot of good stuff going on in there. I think it's also helpful because it helps us as a board connect what we talk about so often at that strategic level to real people, real things, real life, and whilst we as a board have to stay in that strategic space, being able to connect it to the human beings that make up our organisation is really valuable. So yeah, we can have a think about that. Graham, I'll take you next, please.
Thank you. Good morning. Fiona, my question's about national treatment centres, not just ours, which is obviously an area of collaboration across the country, and I think are recognised as one of the big ways of trying to impact on waiting lists and so on. I'm just wondering, based on the kind of good news that's been coming out from our own centre, what the national position is, and how how the national treatment centres work may be developing and evolving in the coming year.
Thanks, Graham. So we're just in the process as a board, and obviously that's replicated across all the territorial boards and the Golden Jubilee, in submitting plans to government with an intention to try and tackle the longest waits within the next 12-month period. So that's not all collated yet. And clearly the national treatment centres like ours that have been operational now for a little while, and those that are coming on stream, or others, hospital centres where there is less impact from unscheduled care demand that comes in variable volume, those centres will play a really critical role in providing the capacity that we need across Scotland to meet the longest waits. But of course, the point that I'll be making in my next report is that where we have capacity isn't always where the waiting list is. So that ability to see the need right across Scotland, and also to see the capacity, whether that's in a national treatment centre or whether that's in one of our established hospital sites that are able to do surgical intervention on people that have a higher level of need or complexity, we have to look at that in the round. So the national treatment centres are playing a pivotal role, and it's good to know that there's more going to be coming on stream over the next period of time. But I think the mathematical conundrum of how we ensure that everybody who has need has a surgical intervention in a timely way requires looking across our existing hospital capacity and theatre suites, as well as those, and mobilising what I'm going to come on to, which is this wider collaborative approach, which is going to require logistical and practical consideration. It's going to require corporate consideration of how we kind of do the business mechanism, but it's also going to require a cultural change for our staff, who are going to be treating people from a wider variety, of geographical backgrounds than they'll be used to doing. So it's quite the challenge. So the NTCs are in the middle of that, but they're part of that bigger system, and we need to be able to see that in the round.
Thank you.
Thanks, Fiona. I had a question, well, not a question, I suppose, just a thought as I was reading through this. there was the under your section sort of quite early on where you talk about, we need to find savings and efficiencies. We need to sort of transfer where we're putting our attention and resources. And I really liked how you said at the end, it may be helpful to think of the financial implications as transfers of budgets, shifting the money to where we need to focus on, from acute into community, reactive to prevention. And I think as I was reading that, I thought, that we know that is a challenge in terms of how we design and deliver care. But I suppose also for us as a board, something that we'll need to take away is that challenge about how do we show that? How do we explain that? We know that the challenges around kind of metrics for prevention is one example of being really, really difficult to do. How do you prove you stop something from happening? That's really, really difficult, isn't it? And I think as we move forward, and obviously your next paper will cover this, but as we move forward, I think we're going to have to think really carefully as a board about how we evidence our work, and some of that will be easy and some of that will be hard. But I think with regards particularly to the finance bit, I think that will be important as well, because I think it would be really easy for people to look at the shifting of the money as pulling away from something, and if we're not clear in showing where it's going back into the system somewhere else, we won't have that balance that we talked about earlier. So I think that's just something for me to take away, but for us to all think about.
Do you want me to come in on that, Sarah? So I think that I think it's essential that we make change that maintains confidence of the public, confidence of the board, and confidence of our staff. And that takes a lot of thinking and a lot of detail and data analysis to help us to make changes in a way that people can believe and have confidence in. And I think some of the mechanisms to do some of what we're describing are going to need to be developed as we progress this approach. They're not ready on the shelf for us just to pull off and utilise. So, I'm very thoughtful as well about how we will show what we're doing and maintain that confidence by being open and transparent about what choices we're making. So I think it's going to need to be developed as we progress forward, but clearly doing what's right for people, meeting outcomes at the earliest time, we intuitively sense to be right. And yet what we see when we look at our investment decisions is that we've often loaded our investment to things that we do right at the end, when it's often late or very late or too late. So it's on all of us to try and really grasp how we start to engage with that intuitive sense of early intervention and doing things proactively. A stitch in time saves 9 approach that I'm sure all our mothers told us when we were young. And yet that's not where we actually load our activity. So yeah, one for us to continue to work on and to develop systems and to think about what does it take to actually do that? How do we maintain confidence while making that shift?
Yeah, absolutely. Okay, great. Thank you, Fiona. I'm not seeing any other hands up, so we can note the report, which segues beautifully into your next item. So this is item number 3. This is on health board collaboration and leadership, and Fiona's going to take us through this one as well.
Thank you, Chair. So as I said, I'll lift the collaboration conversation now up to what's being discussed at a national level. So I think I've updated previously the board through my report on the First Minister's speech in January, and the consideration of governance and accountability that is going to be needed in response to improving health outcomes across Scotland. So both in the Cabinet Secretary's statement to Parliament in regard of health reform in June of last year, and in the First Minister's speech, the principles of improving access to services, shifting the balance of care towards community, and innovation and prevention have underpinned the need for reform. And so for some months, the Chief Executive of health boards across Scotland and the Scottish Government Health Team have evolved their way of working together to create the NHS Scotland Executive Group to bring greater collaboration to tackling these challenges and emphasising a systems leadership approach. The Planning DL 2024 number 31 was published to support population-based planning, requiring collaboration and cross-boundary working to a currently unprecedented degree. So in light of the logistical, technical challenges this will create, along with the questions about oversight and governance accountabilities that have been raised, the chief executives agreed that a common paper laying out a common approach would be tabled at every NHS board in Scotland during the March-April cycle, and hence this report being tabled today. The intention is to offer assurance that the challenges of adopting greater cross-board working will be shared across the wider system rather than be disproportionately shouldered by some areas more than others. So the board are being asked to note the content of the First Minister's commitment and the evolution of new governance, and is being asked to acknowledge and endorse the role of supporting cross-boundary work as laid out in the DL I've mentioned and the NHS Scotland Act, along with their territorial governance role, and to the anticipated pace increasing on establishing the scale of such bilateral, regional or national arrangements. So I'll pause there, Sarah, and I'm happy to take any comments or questions in regard of this report.
Thanks, Fiona. Yeah, I mean, we could spend an awful lot of time picking this apart if we wanted to. So I'm happy to take some questions, but recognising this is kind of evolving. One thing I suppose I just wanted to start off by saying, I might be stating the obvious, but there is already collaboration and cross-border working in place, and we are part of that quite regularly. I suppose what's interesting is the firming it up, I suppose, into this paper, and people will notice that there are a number of recommendations for us to consider today. But let's open it up for questions and comments. I suppose I'm aware that I've been a little bit closer to this through chairs conversations, but this will be slightly newer for other board members. I do also have some other questions, but I'll kick off then. So I suppose the immediate thing for me is, at a national level, this makes complete sense. You can understand the logic of it, using our national resources as effectively and efficiently as possible to meet people's needs. Absolutely get that. I suppose the thing that always comes through for me in any nationally driven piece is, as a board with a very large number of rural and island communities, how does that work for us? Where do we sit in that picture? And I know in particular, there's sort of one, and I appreciate it will just be a bit of phraseology, but there's a bit about meeting the needs of larger populations, thinking about where those waiting lists will be longest and heaviest, but actually, how does that impact our communities? That I think that's of great interest. And the other bit that is linked to that for me is around what are our thoughts around how this potentially impacts or further exacerbates inequalities, not just for us, this will apply everywhere, but if people are traveling further in different ways, if people maybe do need to be away from home longer, that's something that we're quite familiar with already, because a number of our patients do already have to travel. But if that is going to be happening more and more, how are we going to keep our eye on that and make sure that those who find it hardest to travel or be away from home are not negatively impacted by these changes? So those are a couple of thoughts from me to get us going, and then I can see that Jerry will come in after that.
Thanks, Sarah. So, I mean, to some degree, we're heading into the unknown. So it's hard to answer some of the questions other than to speculate. And I think your why now question that you just prompted at the beginning is a really interesting one. So obviously, we do have collaborations, and I referenced those in my first report. I suppose the working hypothesis, if you just look at this numerically, is that we know that we have got theatre time in theatres across Scotland that is fallow or being underutilised, and we've got other people waiting. So at a very simple computational level, we can see how a hypothesis could emerge that matching one with the other would make sense. But of course, what you've highlighted is all of the real life challenges that make that computational model insufficient to really understand whether we can do something about it by moving collaboration to a degree that we haven't done before. So for our rural communities, I think it presents opportunities and risks, as you've identified. So if we have access as a health board where we have openly talked about sustainability challenges, a greater access to hubs or specialist centres that currently we don't have a relationship with or we've not worked with before, then this puts into operation a mechanism by with which we could negotiate more easily or with a greater expectation of acceptance access to services that we've encountered sustainability difficulties with. But of course that requires travel, but it would also require travel if you want people to use where we have the greatest level of underutilised theatre time, which is actually in rural areas. So ourselves, the Western Isles, Jerry, I'm looking to you, but I suspect the island boards, Dumfries and Galloway, it will be these areas that probably have the greatest amount of underutilised theatre capacity. So the travel conundrum will not just be experienced by people living in rural areas, it may well be people living in urban areas or towns that are very used to having services delivered on their doorstep that will get a shock through the door if we don't manage this well, offering them an appointment in Stornoway or in Wick. So that conundrum and the pragmatics of this are part of that journey of change and evolution, where how we talk to the public about this and how we build an expectation and how we listen to feedback about whether that's tolerable to our communities or not will be part of learning as we go in terms of trying to implement the approach.
Thanks, Fiona, that's helpful. Jerry, I'll bring you in, please.
Thank you, Sarah. Fiona, I attended a meeting. I think it was at in the middle of last week, and I won't name any names because I'm not quoting anyone, and I'm paraphrasing. But what I clearly picked up, and I think I'm right in this. There's 100 million, I think, being allocated by Scottish Government for planned care, and the phrase that was used was that 100 million is not coming out to health boards on an NRAC basis. It is actually coming out utilising the summation of all these various calculations which you're talking about, and one of, probably not exclusively, but one of the biggest drivers in that, of course, is the elimination of the over 12-month TTG and the over 52 weeks outpatients, and it certainly the impression I got was that the allocation of funding would be to those boards who can actually probably make the biggest impact on those lists nationally. And actually, so just taking and we're a board where we've got patients who are used to travelling, whether that be into our services or actually to other national or regional centres. But I got the impression that actually what we may well get out of this is a requirement for people to travel for what might be seen as more routine services. So we might actually be doing Clinic A in Raigmore, but other people will be going to the identical clinic somewhere else, because actually that's where they could be seen more quickly. And I just wondered how we were going to probably on a national basis, because I think this could well be a national issue, because I totally agree with your hypothesis that probably the most available theatre time is actually in more remote areas. But I just wondered how we were going to handle, if we put aside the funding for travel and all that, is actually how we're going to handle that messaging of travelling potentially for services which we don't normally expect people to transfer for. And probably just throwing another subtlety in there, are we still going to have the ability to allow people the choice? It says, well, you can travel to the other side of the country and get seen in 18 weeks, or you can come into us, but actually it's going to be 65 weeks. Where the imperative might be to eliminate the long waiting times rather than be seen more locally. And I just wondered how all of these and I know you don't have the answers. I'm just raising them as potential issues. Thank you.
Thanks, Jerry. I mean, I don't have the answers. I'm glad you said that in advance. But I mean, in regard of travel, one of the obviously we've tried to work in this more collaborative way, as I've described in the paper. So the chief executives have used the opportunity of working in that kind of shared space to highlight what some of the enablers would need to be for this to actually work, and the way that we travel routes. So it isn't just whether people are willing to drive their own car, but it's where do the buses go, what direction do the planes fly, which way are the ferries going, are the ferries going at all? I'll say that one quietly. So there's a number of transport related matters that are quite complex, and also our travel policies and our remuneration policies are directed more around planned care than collaborative arrangements for unscheduled care. So these are important issues that will need to be looked at, not just at a local but a national level. But as you were speaking, I wrote access policy, because obviously we have a local access policy around how we think we can fairly work with an individual person around people not attending, people declining appointments. That's all laid out quite clearly in terms of the expectations we have of individuals in participating in their own access to healthcare, and at what point we can draw lines and say, we've offered you fair access and we need to offer that slot now to someone else. So I suspect there will need to be some urgent work on reviewing that access policy, because this will bring a new element or a much more complicated access arrangement when we have, as you say, you can go there and you can have it in this time, or you can go there, and that's cross-boundary. I think probably that chapter doesn't exist in the access policy now, and it will need to be considered. So that's one that I'll take forward and escalate as well, because I think it's a key point. Going back to that point about holding the confidence of the public, I think we as a country have a very strong sense of fair play, and if people feel that they haven't accessed fair play, then we'll soon hear about it. So it's important we try and do that in advance, so people know what the rules of the engagement is, and we can treat people with that sense of fair play.
Yeah, I think that's a great point around that, and thanks for raising that, Jerry, and around that access policy. That's a really good one, actually. Okay, I've got Janice next, and then Anne. Janice, I'll bring you in, please.
Thanks very much. That was there's a lot I think you can build on, as you've said, Fiona. I just wondered at a national level how, and it probably feeds into that last question, how we get that kind of lived experience voice embedded within the pace and the product of this work, I suppose, to make sure that the voices of all areas, but especially we're thinking about Highland, the voices of the more remote areas are heard and are going along in parallel rather than at a consultation phase, if you know what I mean. So I just wondered whether, I know it's early days, whether there's any thought been given to that.
Thanks, Janice. So I suppose for me, I would imagine that the existing mechanisms we have within health boards will need to adapt itself to more deliberately inquire as to people's experience about this particular approach. I suppose there's a nuance to it, Janice, because it's not like a major service change where we say, well, we were offering you a service in building A and now we're not going to offer it there, we're going to offer it in building B. And that has a very regimented expectation of how we engage with the public and then we consult with the public. This maybe has a greater subtlety to it because we're not taking away the original pathway, we're just adding in another one or addending it or putting additional capacity in. So I think there's a risk that of nuance that could get lost here. So again, I've not heard at a national level a conversation about how we hear from the user voice, that lived experience. So again, that's one I'd be happy to feed back up. But I think what I don't want to lose is is our responsibilities as a health board in this to be listening to our people's experience as we amend pathways in this way, and to be able to amplify those voices on their behalf. I think that's a core function for us as a health board, and we mustn't lose that and kind of just give it away to think, oh, somebody nationally is going to be listening to that. You know, we absolutely have to listen to our people and then amplify where we think that there are issues or difficulties, or indeed successes, where people feel that they have had improved access as a result of this approach.
Okay, that's good. Right, this is good. We're giving lots of things to be fed back up. This is helpful.
Yeah.
Okay, next I'll take Anne, please.
So a comment first of all, and then a couple of questions. So absolutely opportunities and risks. I think, Fiona, what I would be feeding back to the chief executives is not just, well, that I would hope that the approach as it develops isn't just about providing assurance that the burdens will be equally shared, but is also about providing assurance that the benefits will be equally shared. So I guess that's my comment. But a couple of thoughts, questions, just picking up from some of Jerry's points. I wondered whether in this whole approach, which, as we said, primarily about planned care at the moment, is any of the extra funding looking like it's going to be spent on other ways of tackling long waits, other than just looking at theatre capacity and trying to make best use of incapacity? So I'm thinking about speeding up diagnostics. I'm thinking about investing in technology and AI developments to help us speed up diagnostics, all of that kind of thing. And the second thing I was thinking for us in terms of our journey, and just thinking about some of our experiences of collaboration with other boards, I'm wondering if we should be asking our professional advisory committees and the ACF for some advice about this approach, and what they see as the opportunities and risks, because in the end of the day, how, and I'm talking about the broadest team of professionals that might be involved in delivering health and care here, how they feel about what's best for the people that they are treating and caring for is, in my experience, often in the end of the day, what might unlock a blockage or encourage collaboration, or perhaps even put barriers in the way. So just a thought about our own journey and how we seek their advice on this. Thanks.
Thanks, Anne. So probably that was my wording in terms of whether we're equally sharing the benefits as well as the burdens, because that was my language rather than the papers. But I think that's right. And as a senior team, we'll be keeping a very close eye on our long waits over the next year. And probably within that, we'll need to see which ones we're tackling through our own efforts within NHS Highland, and then where we've been able to gain benefit from the collaborative approach. But just moving then on to your second question, Anne, that there were two amounts of money that were made available of £100 million, one that's been focused around planned care and one that's been focused around unscheduled care. And the idea of that combination is that the shifting the balance of care, looking at diagnostics, investment in primary care, that supports the access, as well as being the right thing to do in and of itself. So I think I should caution us against looking at the planned care in isolation of the wider operational improvement plan, which is that what we've signed up to as a result of the commitments made in the speech in January. And I think involving ACF is a great idea. I think it's important that, if as a board we've been able to throw up issues to be fed up, I'm suspecting the ACF will be able to do that 10 times over in terms of the practical and cultural challenges to answer the question, well, what would it take to work in this way? And that we can then start to think collectively about how we can overcome any barriers that we've identified to trying to meet the needs of the whole population of Scotland. So yeah, I'm very open to that. But yeah, just to assure that there is a wider approach than just looking at theatres and planned care.
Okay, thanks, Fiona. I've got Emily next, and then Karen. Emily, please.
Thank you. And sorry, I think my connection's a bit dodgy, so if you can't hear me, just wave at me. I guess as a direction of travel, it makes complete sense, but there's a lot that's still to be defined about this, and it looks like it'll be a while before that translates into concrete actions and changes. For financial reasons, obviously, we're in the process of transforming now, and we need to continue to do so. So how do we kind of manage that, or has the government said anything about how they will kind of avoid this derailing existing transformation work if the strategic picture isn't completely clear, because they're still working on what the sort of broader solution looks like? I hope that makes some kind of sense. I guess it's just like we need to transform now, but this could take quite a while to be broadly defined.
So I think, Emily, your question is a sensible one, because you'll know obviously that we're at the stage of the year where we're submitting our annual delivery plan, and the timing of this hasn't exactly aligned with that ADP process, because that would have been a great opportunity, if you like, to subsume the specific aspects of the expectations that were built through the First Minister's speech. So we've had to continue with our ADP work, and then this will need to be addended, if you like, to that, so that it can be seen in the round. Because for our staff that are delivering on the front line, they're not fussed whether it's in the original ADP or whether it's in the addended bit. They just need to know the totality of their work and the expectation of what needs to be delivered by when, and what the oversight and governance of that is going to be. So we're trying to do that in the background, causing kind of minimum disruption, so that our staff are getting a kind of single version of the truth of what they need to do in their part of the work. I think the government expectation is this is going to be something that we work on quite promptly. So they've tried to ask us to create quite realistic plans based on what we currently have, not things that are going to require a significant building change or a significant workforce planning change, because clearly that's not deliverable in a year's time scale. So this particular, both for the unscheduled care elements and the scheduled care elements, we've been asked to send quite realistic ideas of things that we think we can deliver with what we've got, or that can use equipment or technology to create the change, rather than more people that we know we probably don't have to recruit in the area. I suppose one of First Minister's challenges back to the Chief Executives when he met with us is, this is 200 million, but you've also got 21 billion you're also spending. And I think that then speaks to your longer transformation. So there are things that we need to note about this recent operational improvement plan that are very immediate. But when we listen to the speech and the intention, then it is much more about the longer term of how we deliver a transformed health and care system. So there is a further 2 parts of reform that are to come, and that's what I think this collaborative paper isn't just about the immediate stuff. It's also about what's it going to take for us to deliver a really significant transformational change in Scotland. But when those further projects become available, then I will ensure that they're also brought to board for consideration and taking forward. Thank you.
Thanks, Fiona. And Karen, please.
Thanks, Sarah. Thanks, Fiona. Really, it's really interesting, and it's like trying to kind of think about it from a whole systems positive kind of frame. That's what I'm trying to do. I suppose that idea of getting some intelligence from Area Clinical Forum around the practical side of things, because that was what I was thinking. Hang on a minute. If what happens when planned care becomes unplanned care? How do we monitor and cost that out? How do we make sure that we're capturing that information, and just the realities of having realistic times, because someone coming out of area is going to take clinicians longer, just generally. but I think more importantly for me, although, you know, thinking about people travelling up here at particular times of the year, if they've got family with them, where are they going to stay? All of those kind of sensible, practical things that we need to think about looking at Emily. But I think more importantly for me is around the communication. One of the things that we always see in our feedback from service users and families is where there are problems around communication. That's where we get the most complaints, isn't it? And that continuity of care bit. So if we've got someone either from our services moving out or from other services moving in, how do we ensure that we've got that good communication so that people aren't chasing their own information? And I think that's something that, you know, I think would be welcome to see. I think in general we need to improve that anyway, but I think that perhaps this is an opportunity for making sure that that becomes much more a priority for elements of the system that need to work on that. Thanks.
Thanks, Karen. I'll note that point, and I think there's things again that we can hold at a board level, that we should hold at a board level, but there also needs to be really national comms to help people to recognise the change that they might see in what's being offered and to understand why that's happening. So again, that's one that I'm happy to put on the list of things to continue to feed back into the executive group. And any other opportunities I have to influence and engage with our ministerial team.
Thanks. And I suppose just while you were speaking there, Karen, I was thinking there are some challenges that we already experience because we're quite used to sending people, you know, from Argyll and Bute into Glasgow, etc., etc. And I do wonder by bringing this into a national forum, there will hopefully be an opportunity, as you said, for those things to be improved, because it won't just be the problem of a few small boards anymore. It'll be something that everybody's having to deal with, and it might be that that helps us in firming up, you know, how finance flows and is tracked, how performance data flows and is tracked, because that's something we struggle with our SLA and the patient experience. So maybe this is a real opportunity for us to share what we already know about moving people across boundaries and getting some support or some more eyes on it to see how that can be better for everyone. And I'll bring Katrina in, please.
Thanks, Sarah. Just briefly to say, I think our next ACF is 1st of May, which is quite timely. So I think I can catch up with Fiona during April at some point to draw something together. The ADP is already on that agenda, so it won't be too challenging to actually add in a bit of meat to that and make it a bigger discussion point. And I think the ACF will actually welcome there being a structured point for discussion as well, which should add value. So yeah, more than happy to catch up with you, Fiona, with regards to that.
Okay, that's good. That sounds like a great opportunity and good timing as well. Okay, thank you, colleagues. That's been a longer conversation than we had timetabled, but I think it's a very significant item. So I think that's been really helpful, and we've given Fiona some really, really good contributions that can be fed into wider conversations. So I think that's been really important. I'm not going to read out the recommendations word for word. You've got them in front of you. But, you know, so we're being asked to note the commitments set out by the First Minister and what we'll need to do around assurance, the evolution of the governance, and we've been asked to acknowledge and endorse the duality of our roles, so for our population and the wider system, and that piece around pace of change as well, and to note that there is a requirement to refresh our approach and objectives as referenced in the letter from Caroline Lamb on the 7th of February. Given the discussion and what we've fed back, are people content with that? Okay, so watch this space. It sounds like this is going to be a moving feast, so we will keep you posted. Okay, thank you, Fiona. Right. That takes us on then to item number 4. So here are our minutes from our various committees, and you will see that we are trialing something a little bit new. We have got a little brief summary document which allows the chairs to just note any items to bring to the board's attention, and we're just trying to put a bit of structure around it to make it more consistent and easier to follow. Now, I'm not sure if I can't remember what time Alex said he was back. Because first up we have FRP. I'm not sure, Alex, if you're with us. No, I don't think he's back yet. Okay, that's fine. What we'll do is we will just have a look at that. If people have questions and comments, we can take a note of them and pick them up with Alex offline. You will see that we've got 2 sets of minutes. So we've got the 7th of February and we've got the 14th of February, and we've got, sorry, 14th of March, and we've got the summary there. So, and you'll see the structure of it. So we have alert, assure, tells us what we can get assurance from, advise, so just a bit more information there, and actions and learning. So I'm happy to pause here and take any questions or comments, which we can hold for Alex. No, okay, that's great. I will move us on then. Next up, we have staff governance. So Anne, I'll hand over to you, please.
Thanks, Sarah. Well, you have the report. We had a very full agenda and a good meeting. I think the things that I would particularly mention, it is taking some time to get to the bottom of what the barriers are to raising our appraisal and PDP rates, but the committee had a quite in-depth discussion of this with update from Gareth about the work that's going on. And I'm sure that the committee going forward will be keeping a very close eye on the work of the Short Life Working Group that's going to be set up to try and address the issues that there are, whether they be the technical ones or the motivational ones, to raising these really important metrics. I won't mention the various items that are on our own agenda later on today, but just also briefly to highlight the work that was reported on staff engagement, the digital and face-to-face focus group type sessions that were carried out to take a deep dive into our iMatter results. And I would recommend reading the staff governance paper with the feedback from those engagement sessions, because it made for very interesting reading. And then finally, just to draw your attention to the fact that we did receive an assurance paper on the process for agreeing how we will provide the confidential contact service going forward that the Guardian service currently provide. We've previously at board level had a report on that, and the work of the options appraisal is complete, and a way forward with a funded in-house service has been agreed, and that will now be progressed. So that's it, I think.
Thanks, Anne. That sounds like a full agenda, and as you said, a number of them coming on our own agenda later on today. Any questions or comments for Anne? No, okay. Thank you, Anne. That's a helpful update. I will move us on then to Highland Health and Social Care Committee, and Jerry's going to give us a summary from the 5th of March.
Thank you, Sarah. I realised utilising the new format of a summary of the meeting, I had perhaps got too keen on the summary version of it when I was making my writing down some thoughts to pass on to colleagues today. I won't go through all of the items that we went through, but we received some good assurance reports at the committee at the beginning of March, and we're managing now, I think, actually to get each of the agendas quite thematic. So we had quite a theme running through this of community-led support, particularly in relation to self-directed support and obviously within carers. I think one of the issues which really came across in both of those reports, or one of the main issues that really came across in both of those reports, is and it is a stumbling block at the moment, that the absence of a really well set out defined commissioning strategy is actually now becoming a little bit of a barrier in terms of how we and maybe not in terms of how we do things, but actually how we communicate, and people have got a clear statement of their intent and where we want to go. And I think that came across in a couple of issues in there. We received a closure report in relation to care governance from Ruth MacDonald and Dr. Copeland. And I think we've made some good progress in there. But I mean, I think the only caveat that I think the committee would probably like to pass on to the board is that it's still very much a perception, whether it's reality or not. But there's definitely a perception out there that care governance is very much still the poor relation to clinical governance. I don't think that was, and it's not getting the place that it probably merits in there. And I think that's something, that cultural piece is something we still need to just work way through there. And I think the advise bit, I think, and Helen will probably pick up with this in her finance paper, but I think we cannot underestimate the impact of the employer's national insurance change is going to have in the third sector, in the independent sector, let alone on our own services. Because I won't talk about anything that Helen's going to talk about later in the agenda. We're definitely seeing that rising as an issue in there. Ties into our commissioning strategy, but of course this one is probably more linked to just there's an absence of funding for these things, and it is going to have, and all the strategies in the world are not going to magic up the funding for the employer's national insurance impact, and it's how we're actually going to the impact that's going to have on our independent sector and our third sector, and how we're actually going to manage that moving forward. And probably one final point, I noted at the committee, we now have no lay members on the committee. We now have 3 vacancies, and I undertook to pick that up with yourself at our next one-to-one, just in terms of how we progress that. Thank you, Sarah.
Thanks, Jerry. And yeah, I know we've had a couple of sort of protracted conversations about that in the past, and I think there's a real opportunity for us to consider where and how lay members contribute, and I think that's a big question. And it would be something that we would need to consider anyway, but I think we're at a bit of a juncture, aren't we, when we consider the future of health and social care integration in the Highland Council area and how we do that going forward. And I think that's a really important question. I can't help but draw comparisons as to how we've done it in the past in Argyll and Bute with our strategic planning group and our locality planning groups at a more local level. And so I think there's something for us to really think about, because that lay member, public representation, although we are obviously all members of our community and represent our communities as well, but that lay member representation and lived experience and carer reps, they're really, really important. And there's something for me about where that is and if it's at the right point in the journey, because there's a bit about where do people influence and where do people hold to account, and they're not always the same place. So I think there's something for us to take away and have a real think about, because I don't want us to just be putting members on just for the sake of it. It has to be meaningful, both for us and for them, so that it's not an incredibly frustrating experience for them as well. So I think that's something for us to take away and have a hard think about. Okay, thanks for that, Jerry. Any questions or comments for Jerry? No? Okay, I think your point about care governance was really well made, Jerry, and that segues us beautifully to Karen, who's going to give us an update from the Clinical Governance Committee.
Yeah, thanks. Thanks very much, Sarah. And Jerry, I think you and I agreed we'd have a chat about care governance and clinical and care governance. So that's something that we can hopefully pick up over the next few weeks. So thank you. You have the report, the summary report available. It was my first committee as chair, so that was interesting for me. The usual busy and to note, of course, the continuing work on the vascular service and a wider conversation that we held during the committee around risks, potential risks, and other services that may be at risk, and how we can improve our intelligence around that moving forward, and the difficulties of doing that sometimes as well. Specifically note the improvement insurance work
assurance work around the Highland Transfusion Committee. A really excellent report from the lead for that group. And that was very welcome and really brought a lot of useful information and assurance to that very important service area. We are looking forward to receiving more information on governance and assurance around infant children and young people with the formation of that clinical governance group, and I think there is quite a lot of work to be done in that area, and hopefully we can, as a committee, support that work as that moves forward. And in general, I think for me, looking forward to working with the executive members on the next phase of clinical governance, taking over the stewardship from its previous chair. Thank you.
Thanks, Karen. Any questions or comments for Karen? No, okay, thanks. And I'll move us on then to audit. So Emily, I'll invite you to speak.
Thanks, Sarah. Yeah, we had a very full agenda, particularly the internal audit section. I'll take the paper as read, but we had 3 reports coming to us on awareness of fraud risks, devolved procurement processes and supplementary staffing. All of those were quite meaty topics, so that was a good discussion. We had Audit Scotland come and present to us some of the detail of their latest NHS in Scotland overview report. I'll drop a link to that in the chat. It's a good read if anybody's not had the chance. But it was, I guess, my biggest takeaway was there were no huge surprises, but it was good to know we're not alone in a lot of the challenges we're experiencing, and also a lot of the recommendations that Audit Scotland were highlighting specifically for the government were definitely things I think we would all agree with. There was huge progress with the management actions. We were able to close down a lot of those, and that's thanks in no small part to Heleth, which I did highlight on the meeting, but there was a real push to get the ones where we were missing updates updated, and we've been able to close and or downgrade a decent number of them in that meeting, and it was just a much more satisfactory picture than we'd seen in December. So thanks to everybody that was involved in improving the picture there. Fiona, I know you were also very much involved with that, so thank you. We had a couple of challenges with quorum, so I'd like to thank Jerry and Joanne for stepping in, because with a very limited membership of audit in general and 1 seat currently vacant, we don't have a lot of scope for people to be away or having to step out. So very grateful to colleagues for acting up for that meeting. That was really appreciated. The only thing to escalate was really around the children's services audit. We understood there'd been quite a lot of progress made with that, and it's due to come to the June meeting still, but that was very much with a proviso that work has to start imminently. And the indication from internal audit was that, having seemed to agree a scope and a way forward, things had gone back the way a little bit. So I don't know if Fiona might want to add something on this, but it just seemed like perhaps some of the progress we thought we'd seen has gone back a step. And given that we escalated before, the fact that this has taken such a long time to come to fruition, I just felt it was something that we should be escalating again for awareness of the board. I think that's it for me. Thank you.
Okay, thanks, Emily. Really good to hear that those management actions have been have had a good blast. So thank you to everybody on that. I don't know, Fiona, do you just want to comment briefly on the children's audit, please?
Shall I let Heleth come in first, and then I can? Yeah.
Thank you. I can just give a brief update to say that it was flagged again at the Joint Chief Execs meeting, and subsequent to that, so I think last Friday, our auditors did meet with the council auditors and the managers from both sides to agree a joint plan. So that is in progress.
Okay, Fiona, I'm assuming you don't have anything particularly you want to add to that, or?
Well, it's just to say that it's been a regular topic on the Joint Chief Executives meeting, so that we're keeping a watching brief on it. Helen's obviously there given the detail of what's fallen out of that, but we won't be taking it off that agenda until I've got full assurance that we're not just planning well, but we're doing well, and then we'll all look a lot happier, and we'll look forward to the June meeting. Thank you.
Okay, that's helpful. So we'll keep that up on the hot list until we feel better about the progress. Okay, that's helpful. Thank you. Any other questions or comments for Emily? No, okay, thank you. And as Emily said, thank you others for stepping in to support the committee. It's much appreciated. Okay, we have our Argyll and Bute Integration Joint Board from the 29th of January. Graham.
Yes, unfortunately I wasn't at the meeting, but I'd been filled in since I was on holiday at that time. But you'll notice a couple of points. One, that we're now back on in-person meetings, hybrid of course as well, given it's Argyll, but in-person meetings which we're hoping will allow just a greater airing of issues and you know, and different members being able to work together better. You'll also note that the continuing challenge that we have in Argyll with filling vacancies, and that's reflected at the leadership level, the number of interim heads posts that we have, which is concerning. And that's not a reflection on the people covering in these positions, but we all know that it's much more challenging to act strategically when when you have a whole lot of senior posts just filled on an interim basis. So that's something that we're working away at just now. The care governance one, I'm guessing, well, we know that this isn't just NHS Highland one, it's a Scotland-wide, UK-wide as well for that matter, about just about how it's, you know, the kind of idea of a second-class service rather than very much integrated part of our health service, health and care service, really. Unfortunately, there aren't any quick solutions, but we don't seem to be making much progress nationally on this. And I suppose our concern is that at times of budget cuts, and particularly in Argyll and Bute, where we have a disproportionate number of older people, that budget pressure then comes through on the care side disproportionately, particularly for more elderly members of the community. So it's a challenge for us, and I think it's one we're going to be revisiting frequently. Thank you.
Thanks, Graham. Any questions or comments for Graham? Okay, and of course, Graham, you'll be stepping into the chair of our IJB imminently. So.
Yeah, we have of course, the schedule always is our meeting follows, so it's tomorrow with our last with the last meeting of Councillor Dougie McFadden, who's been an excellent chair. Be a hard act to follow, but we're looking forward to working closely together.
Yeah, no, I think it's really positive, and I suppose been able to experience some of the positive work locally, and because of where I live, so it's great that you'll be able to continue to work together. Okay, any other questions or comments on that? No. We do have Alex back. So Alex, we have taken the reports as read, but I'll just pause briefly, Alex, if you wanted to jump in with any big flashy items.
No, the only thing to mention on the 7th of February meeting was the business continuity investment plan. Now, that's actually a lot of money. We talked through that quite a bit, but that's coming to the board. I don't know exactly when, but I think it's quite important. I think the thing that really worried us was the Scottish Government's thing about it's basically pointing to breakdown maintenance rather than any proactive way forward. And that's not a good approach. But unfortunately, that's the approach the government seems to be taking. So it's something we'll keep an eye on as we go forward in terms of performance. The only other problem we had with the last meeting, because of pressures of work, etc., some of the papers didn't get to us to a very late stage, so we had to defer them into the next meeting. But hopefully that won't be happening again. Thanks.
Okay, that's helpful. Thank you, Alex. And we'll keep an eye on that investment plan work as that moves through. That's important. Okay, thanks everybody. That was really helpful. So we've been asked to confirm that we've taken adequate assurance from our committee and note those meetings, summaries and actions. And offline, if people have feedback about that form that we're trying, I would welcome any thoughts to see if that works for us. Right, I'll move us on. We are fairly behind schedule, but what I'll do is I'll move us on. We'll take the IPQR and then I think we'll have the break after that. So David, I will hand over to you to take us through our performance and quality report, please.
Thanks, Sarah. Good morning, everyone. Hopefully colleagues will have got the report in their pack. It's in pages 268 to 307 in the combined pack. As you've probably just heard, the contents of the report have gone through the various committees of clinical governance, staff governance, and finance resources and performance committees already, but a subset of that is available to you as it combines together in our board IPQR for our March meeting. Just a few highlights for you and then give you as much time for questions as you would like. I fully agree with Steve's comments at the beginning about trying to remain positive. It's particularly when it gets to performance, you often look at the negatives and say where we're not meeting what we would hope to meet. But keeping it in context is always helpful, and therefore, in as many cases as we can, we try to share both our own position against what our plan was, as well as what our own position is against the national position, which gives a sense of context in terms of some of the challenges that we face. A few highlights for you. CAMS continues to make progress with regard to reduced waiting lists. It's not quite coming through in terms of the actual episodic performance as yet, but the team with further recruitment in train expect to be able to see some positive benefits from that in the coming months. Alcohol brief interventions, after a period where we've been below target through the year, have now recovered and are above target, so that's good news. From an unscheduled care point of view, it still remains a challenging environment. ED performance is relatively static and reflects that ongoing pressure that's experienced both by colleagues working in that area, but of course the public who are experiencing it. Delayed discharges is one of the contributing factors toward that. It's showing some signs of improvement, but we need to be confident that we're able to sustain those areas of improvement, and that forms much scrutiny both internally as well as with Scottish Government with regard to those plans. From a scheduled care point of view, a much better news story across outpatients, TTG and diagnostics. We are largely on plan across the board. We are relatively favourable in most of these areas in relation to the national picture, either on national average or above national average. And again, as I mentioned the last time, that's particularly important when we are making bids for additional funding, where we've got a track record of not only being able to meet our commitments, but also meet any additional commitments associated with funding that would come our way. So that's a very important area for us. Cancer performance did take a dip in January. That was predicted, and that's not untypical of a January period where you've got extremely time-bound activity related to which is typically a holiday period. Then it will have an impact in terms of performance. The update that we did receive at EDG yesterday is that the February numbers have recovered from that, which we'll be able to report at the next meeting. If I can say it, psychological therapies is another area of success. It was an area of concern for some considerable time from the board, but the performance is significantly better and has maintained that. Not quite at the national target, but we are very high performing compared with other boards, and credit to the teams who've put in so much effort around that space, and not content with the current performance, they continue to look to improve. Complaints have seen a slight improvement in response rates, but still a way to go. And the patient focus area in the report is around the patients with dementia. There is some information with regard to falls as well as tissue viability, and some of the staff governance metrics we've already mentioned as the earlier part of the report, where we are still seeing an improvement in time to fill timescales, as well as improvement around compliance to statutory mandatory training, which is still going upwards, albeit we'd like it to go at a faster rate than it is. It's still going in the right direction. So I think with those comments, I'm happy to open up for questions from colleagues, and supported by other my exec colleagues on the call, as well as Jane and Heather, who are joining in Catherine's absence today to answer some of your questions. Thanks. Alistair, please.
Yeah, thanks, David, for a really helpful introduction. It's actually answered a couple of my questions, which is great. Now, I note the improvement in CAMS, but obviously NDAS still remains a different challenge. I suppose my point is associated with the transformation fund held by the council of 20 million, which is to enable a shift in some of the issues that we're experiencing, especially around delayed discharges, care at home, adult social care. I just wonder, is it worth in future IPQRs listing on the individual pages where it might relate to the item that might be the transformation item, and how it's progressing in terms of what the financial element of that was, because I think we're starting to look at things a little bit in isolation if we don't build in a substantial transformation fund into the IPQR, and perhaps focus in what we're doing with it and measuring it at board meetings to make sure that we actually are getting the shift that we're actually requiring on that. I think that'd be a useful thing to do, and it will certainly help show the situation on delayed discharges, if they're held up for care homes, care at home placements, or other things as well. I think it'd just be helpful for me anyway to see that in the remaining time that I have on the board, because I'm not far behind Anne.
Thanks, Alistair, and thanks for your interest around the area. I see Fiona's want to come in, but just to mention, I think it is an area of focus between ourselves and Highland Council in terms of using that transformation fund, and forms, I'm sure, very much part of the focus of the Highland Health and Social Care Committee, where it can devote a little more time and space to that. But Fiona, did you want to come in on that topic?
If I may, thank you very much. Alistair, I think it's a really interesting question you've asked, but if I step away from the way that you framed it to how it makes sense to me, which is how are the council and the board working together to transform services, no matter what the route of funding or underpinning, and to me the governance of that is the joint strategic plan. The purpose of the joint strategic plan is to describe a vision of what we want to get to in delivering integrated health and care services, and then to monitor ourselves against delivering it. So although the council have made that specific pot of money available, it's very welcome, don't take it away. But I wonder we're going to get into very confused governance if we're monitoring, if you like, a council-led initiative in the health board that we need to look at through the joint strategic plan. I wonder we need to kind of take that away out of the meeting and have a little bit of a sit down and think about what is the best mechanism for assuring ourselves that change is happening, no matter where the funding is coming from, but also to assure ourselves, those that govern particular pots of money, that it is being spent in line with public value principles. So I think we probably can't answer it here, but I think it's a really good question for us to sit and just make sure we're not going to get in a tangle, and that we're driving change, which is the most important thing.
Thanks, Fiona, and thanks, Alistair, for the question. Sarah, can I come to you, please?
Thanks, David. Just having a look at the vaccination, I can't say it either, the vaccination data. And I suppose the MMR bit caught my eye, both in terms of where we are against that kind of national average, but the fact that when you look at the national average itself, that, you know, there's a slow but unmissable decline as well. So I suppose actually my question is about national work around this. I don't know if Public Health Scotland, for example, or someone else is looking at investigating the drivers behind that. Clearly, I understand there's kind of, you know, work that we do locally around messaging and delivery and access. But if there's a bigger kind of change around vaccine uptake nationally, I don't know if there's national pieces of work around that. Thanks.
Thanks. I'm sure Tim can come in and help to that discussion. Thanks, Tim.
Thanks very much. Just a note about the vaccine information. There's actually an update to that which is very hot off the press and was published at 9:30 this morning. But it essentially doesn't show very much of a change. There's nothing significant really different from these. They're quarterly figures. So the ones that just is published is October to December 2024, but it is very similar to the quarterly figures for the previous quarter, which are on the IPQR. What that does show, I'll come to the MMR in a second, but what the IPQR and the more recent information does show is the opportunity for improvement with the 6-in-1, in that the numbers certainly had gone down and were very concerning, and we've discussed in detail issues around vaccination before. But there has been significant improvement with the 6-in-1 getting up. I think Highland HSCP figures for that came out this morning were 94.1% for the 6-in-1, which is still marginally below the Scottish average and the level that we hope to get to for the World Health Organization 95% threshold, but it is still actually so it shows some promise and is a lot better than it has been. What that demonstrates is it is possible to improve quality. It is possible to turn vaccination around, and I hope we can work with that on MMR. There is a national recognition about the need to improve the MMR figures, but I think that the drop off, particularly for MMR, as opposed to others nationally, does show that there's something going on, whether around vaccine hesitancy or some uncertainty perhaps around the effectiveness of vaccines, that definitely needs to be picked up. There is national work that's going on, particularly around MMR, but I think we need to push on that both nationally and particularly locally, as we are low down in the pack. Certainly Highland HSCP, Argyll and Butte's probably around tends to be around the national average.
Okay, thank you.
Thanks, Tim. Thanks, Sarah. Jerry, can I come to you, please?
Thank you, David. First of all, I would like to just acknowledge your opening remarks in terms of the, I think, broadly positive messages which are contained within the IPQR. So I'm not going to delve into those areas where maybe we would like to be better, but we know what we're doing, and I think that's what's demonstrating. I will ask a question about delayed discharges, much as I dislike asking a question about delayed discharges, is when do we anticipate our actions actually having the impact that we would hope they would have, and indeed if we're still expecting them to have the impact or factors have changed. And probably a second question as well, again, probably coming out of the meeting I attended earlier in the week, where we get into the discussion about planned care, and I heard the phrase that I've not heard for quite a while, and for those of a certain vintage will recognise the 3 letters of TCI dates. and they appear to be coming back onto the table. And this may well be a discussion for the Finance Performance Committee, David, so absolutely happy to have it there. I just wondered what our approach is going to be to come in dates and communicating with patients on our list and all that as we begin to move forward. As I say, I've not heard that phrase for good reason, for probably since 2019, but it was certainly mentioned this week in meetings we were having about planned care. Thank you.
Yeah, well, you certainly caught me out with that acronym, Jerry, and that's not just about
what you're talking about.
That's not about age, that's just about time in the NHS, so don't worry. But let me talk about delayed discharges first of all. I'll come to Pam, and then I'm not sure if Evan wants to add anything from an Argyll and Bute perspective thereafter. Pam.
Thanks, Jerry, for the question. Just in terms of impact, we monitor very actively, so weekly through the national group with the other chief officers, but also within the board, providing fortnightly assurance to the executive directors group and a weekly report out to the chief executive. And of course, the invitation's open to the chief executive of the council as well for that report out. So we do make a number of impacts which sometimes are lost in the higher figures. So we've stepped up some capacity within our statutory run care homes, which has provided options for people, but perhaps just looking at the data we're reporting or the trends that we're reporting within the IPQR, that might be lost. So we need to maybe show our interventions so that they're understood about, how people have moved through our system, and we've been looking at developing data sets to understand that much more actively. So, for example, last month we started a new project, having an EHP at the front door. Now that's beginning to show us and tell us that we're able to directly intervene and support people, and help them to return home with that active assessment and support. But that's not seen in the figures that we're looking at in the IPQR. So perhaps a revisit of some of that in terms of the narrative might be helpful for the board going forward. But for assurance, we've got internal and external scrutiny around this, so that we're understanding all of the impacts of our interventions, and also learning from other systems and having national input and support from a lot of the national teams as well. Thanks.
Thanks, Pam and Evan, from an Argyll and Bute perspective. Do you just want to add a bit of flavour as well, please?
Yeah, absolutely. So we're currently going through probably a trickier peak around delayed discharges within Argyll and Bute, which we monitor through our senior leadership team. It's a really difficult question, Jerry, to kind of separate out the impact of our actions from the kind of increased demand that we kind of know we see in our broader data. Some of the work that we got ongoing is we know the right stuff around moving towards kind of more proactive models of discharge, and I think we know nationally there's nothing new there. We just need to keep on doing that, and there's work still to do around embedding our reablement and kind of integrated discharge model across our community teams. There's also kind of work that we kind of have a recent kind of renewed focus on relating to Glasgow and the way, because probably about half of our delayed discharges sit within the Glasgow system, and the kind of interfaces between their kind of discharge processes and our discharge processes aren't always comfortable, and getting the early visibility of those people and their kind of likely pathway through the hospital system, so we can begin our planning earlier within Argyll and Bute. That's an area we're working on with colleagues in Glasgow. So I mean, as you know, it's always really multifaceted.
Thanks, Evan. And I'll bring in Jane Buckley. I think colleagues will know Jane as the head of operations for our Inverness Hospital, so for Egmore and NTC, and she'll talk just a little bit around our access policy, which is what Jerry's comment was relating to. Jerry, hopefully we've passed the test that you set us, but Jane.
Thanks, David. Yeah, TCI, I haven't heard that one for a while either. But yeah, I mean, we have got a very ambitious scheduled care plan for 25-26. And, we were actually discussing some of this yesterday at the Executive Directors Group. And the fact is, how do we keep our patients informed with regards to the progress on that waiting list, because, unfortunately, we do have long waiters in some specialties, more acute than others. And of course, as the focus from the Scottish Government is about that long waiting patient, those over 52 weeks, and the target of eliminating all of that wait before March 26, it's even more important that we are keeping our patients informed, applying our local access policy, making sure that our waiting lists are validated and clean, and that people are ready, willing and able to accept those dates. Because that's supposed to be the deal when they're referred, isn't it? That they are ready to proceed. And quite often we find that that's not the case. We've got to do a lot of work with our primary care colleagues and, in fact, our patient education. So just to reassure you that there's a lot of housekeeping and rigour going into ensuring that our waiting lists are as accurate and as up to date as they possibly can be, and keeping those patients well informed about current waiting times as we go forward.
Thanks, Jane. Thanks for the question, Jerry. Anne, can I come to you?
Thanks, David. This is probably a question for Louise. I would think. It's just something that caught my eye as I was going through the IPQR, and it relates to tissue viability, the information on that. I wondered if somebody could just say a little bit about why that work is rated red, but also in particular in terms of the plans and mitigations. There was a comment about that we should be considering lowering the median so that we have more strategic and realistic targets. Not being anybody that well versed in statistics, I wondered if somebody could just explain what's going on there and why that's considered appropriate. Thanks.
Thanks, Anne. Louise?
Thanks, Anne. In relation to tissue viability, one of the challenges that we have is really understanding where our priorities are, because it is a very defined and quite a small service. So what we're trying to do is make sure that we're absolutely targeting the very small resource around tissue viability specialists in the areas that they need to be, and that's why we're trying to look at those figures and see where that hits. But also, whilst we're doing that, keeping ourselves running by making sure that everybody else at less specialist level has the expertise to do the work on all of the other people that don't fall into that high category. The reason the rating is red is that we've got a national target of 20% reduction, and whilst we have had periods where we've had some level of reduction, it has still gone back up again. So we need to get to a sustained position of improvement, and I don't think the team feel that we're yet at that position.
Okay, thanks, Louise. Thanks for the question. And Alex, can I come to you, please?
Yeah, thanks, David. It's good to see some of this stuff, in fact, quite a bit of the stuff improving. That's excellent. I'm delighted with that, like Jerry said. On the organisational metrics, the bit that worries me a little is the recorded absence reason. It's been stubborn for a year. It's been sitting, it's gone from 74 to 75.9. There really isn't much of a change, although the graph looks like there is, but numerically there isn't. Do we understand the why of it? I can see in the narrative managers being asked that they should be putting down reasons. Do we know why that has been stubborn through the process, Gareth?
Yeah, go ahead, Gareth.
Yeah, this was a subject of audit that we completed and reported through audit committee. So we did explore the reasons for a recorded absence. So that primarily is to do with some of the mechanisms by which people delegate responsibility for taking calls from people that are phoning in to work, particularly on short-term absence, and updating. And we're looking at that. We're bringing in guidance, a little bit about lack of clarity on what should and could and can and can't be divulged to somebody that is effectively had that delegated from the line manager to them. So it could be an admin member of staff that's just from a practical perspective taking a note of who's not going to be available for the shift today, and then being able to follow that up with actually the reason. So I think it's a little bit akin to when you visit your GP practice. You do have to say, you have to say what the issue is with your why you want to have an appointment. That usually is an administrative member of staff that you're talking to. So it's not to say it's not possible. I just think people felt a bit uncomfortable with what they could and couldn't ask in that space when it's been delegated to them. So we think that is one of the key areas for us to focus on, and some guidance in that area. Whilst it has been relatively stubborn, there is some uptick there, so we are continuing to look at it and focus on that. But that's our main hypothesis at the moment as to what we need to improve.
Thanks, Gareth. Thanks for the question, Alex. I think that's the end of the questions. If I can just take a moment just to remind colleagues, or particularly related to the subcommittees and the exec leaders as part of that, as we approach into 25-26, it's an opportunity just to refresh, be content with the reporting that's being done, that gets collated through the IPQR. So in terms of the reporting that you both receive as well as pass on from your committee to the board, just ensure that you're happy with the frequency and the content of that data, and it's looking at the right metrics as we get our ADPs approved. So it's a bit of a work in progress. I don't expect it to suddenly change from one moment to the next, but it's just a little prompt and reminder that is a good time of year to start thinking and considering what each of the committees may require, and therefore what gets collated into the IPQR may change. But thank you all for your questions, and the feedback is always welcome. And I'll hand back to the chair. Thanks, Sarah.
Thanks, David. No, I think that's a really good point. This is a good time to kind of recalibrate, recognizing that the IPQR sort of constantly evolves and has to be sort of reshaped back to where we want it to be. I think that you're right, it's a good time of year to think about it, both in terms of the ADP, in terms of what we talked about at the top of the meeting, and I suppose looking to the future, where do we want our focus to be, and does the IPQR reflect that? So I think that's a good reminder, David. Thank you. Thanks for the questions, colleagues. We are being asked to take limited assurance, note the continued and sustained pressures, and consider the level of performance across the system. And just to loop back to something David said at the beginning, I think it's good to try and get that balance from the overall picture. There's clearly always going to be bits of the system that are kind of under pressure and require improvement, but it's good to see the bits of the system where we are making progress, and that is evidenced by the data. So are colleagues happy with that recommendation? Great. Okay, we're slightly behind schedule and slightly going to jig things about, in the sense that I'm going to suggest we take a break right now, and we'll try and make up some time after the break. So it's been quite a heavy start to the meeting, so we'll take a little bit less than 15 minutes. I'll see you back here at 11:30, please. Thanks.